So again, I'm going to use this would be my mobilizing hand, this will be my assisting hand. So the first part is really called assessing or scanning. You can see his ears shake when I do it. That's how big the restriction is.
It's a big one. I can feel it.
He doesn't have that here. This is the same depth. You can see it. I don't need a stainless steel tool to feel this. This direction, not as bad. You feel that?
No,
it's still there, but it's not as bad as it is in that direction. So typically I'll choose if I want to be the most aggressive, and also I think the most effective, you want to choose the most restricted direction first. And I'm going to really wind that up. So this is held at about 45-degree angle to the tissues. The least aggressive side for things like arms or legs is the big concave side. Then you could progress to the largest convex side, then progress to the second largest convex side. And this is mainly for either small areas like between bony contours of metacarpals, carpals, or to go between things like intercostals, or to just do transverse friction. So on a patient, I would start off like this. But since it's Tony, I'm just going to go right to here. I'm still going superficial.
You should save your hands.
What's that?
Don't save your hands.
Oh, yeah. I'm in my mid-30s, but before I was using tools, I noticed even by my late 20s that my hands felt like crap. I mean, and really, my hands have felt a lot better since I started using this, because I used to do this all by hand. The thing is, eventually your hands, I said my hands never been a patient that they couldn't beat, but eventually they would have. But typically, most tissues are going to give to stainless steel. Plus, again, it is a bit more sensitive. You can feel that softening up, right?
Mm-hmm.
I'm going to go this way now, be a bit more aggressive or transverse. And if you can tolerate it, I'm going to pull away for a little bit more stretch.
And as an aside, this isn't even addressed in all of the mechanical program, MDT. Not brought up, doesn't exist. It's all dysfunctions of the repeated movement, and I just think that this gets in there so much quicker and so much.
Is it still there? Yeah, but look how much deeper I can push now. Now, what would you have done pre and post, other than just this, which I would document as, moderate restriction in upper trap? You could say it's, at the junction between the neck and the upper trap, or around C7. But I would also document the direction. So it's a moderate restriction in upper trap, from proximal to distal, or from distal to proximal.
And for the assessment, you'd say minimal restriction, proximal distal, following,
yeah.
Tool-assisted soft tissue.
But I also would have had some sort of something else. I would have checked strength. I would have checked something simply objective.
So just do a baseline.
Yeah.
Do a baseline and let this go instead of your repeat.
Whether he was limited in shoulder elevation or cervical side bending toward or away, he would have had some sort of restriction that would have brought me to this area in the first place, and then I would measure afterward. And that's the thing where, again, if you're going to do this on a patient, you better be able to make an improvement because it's going to hurt. So